nurse managers have to teach nurses to do it differently. But they get the benefit of, you're not going to have a lot of nurses hanging around at the end of shift getting overtime, right? So it's also going to increase your bottom line, which hopefully allows you to put more money into other things in the unit.
Hello, this is Zach with the American Journal of Healthcare Strategy, and you are listening to the Clinicians and Leadership podcast, where we focus on empowering clinicians from bedside to boardroom. Today, I am joined by Dr. David Wilcox. Dr. Wilcox, why don't you take a second to introduce yourself? Tell us a little bit about your experience in your current role and what you do.
Okay, thanks, Zach. It's a pleasure to be with you today. I am a doctorate prepared nurse, so I have a DNP degree, which was a life accumulation of many degrees. And so I'll talk about my why. Why do I do healthcare? I have a special needs daughter, and I had her early when I was young, about 17. And I would be dragging her around to doctor's appointments, various doctor's appointments. And I saw a lot of really good clinicians, but I saw a system that was really broken. And I was in manufacturing. And when I got laid off from manufacturing, I decided I wanted to be a nurse. I had about a year of unemployment benefits. So I became an LPN, licensed practical nurse, or LVN in the state of Texas. And so I did that. And right away, I loved doing something where I really affected people instead of making parts in manufacturing. And so from there, I immediately got into community college to get my RN degree. I got my RN degree. And then my girlfriend at the time, who's now my wife, and I moved down to North Carolina from Syracuse, New York. And there I was a float nurse. So I was floated a lot to the emergency department, right? Because they're always short-staffed. And I was able to de-escalate situations. So about a year in, they approached me and asked me if I would be the night supervisor. And I said yes. And so I began my jump into management, right? And so as a night supervisor, I would have patients that would hold in the ED. And the CNO came to me one day and she said, "Why is it when you're on, we don't have a lot of patients holding in the ED?" And I said, "Well, that's because I go up and talk to the charge nurses at night at like 2 a.m. and say, hey, can you stretch? Somebody's grandmother's in the ED. And, they're in a real bad state down there." And she said, "What do you do if they say no?" So just come down and check the patient out for me. They come down and 100% of the time they take the patient. So she asked me if I could do that for the whole organization. And I said, yeah, I think so. So I became the patient placement director and had the staffing office and had all these, departments reporting to me, and they were just giving me everything that was broken operationally and asking me to fix it, which I really thrived on. I liked it a lot. And so with that, I had to go back and get my 4-year degree. And so I got my BSN, right? And then from there, I was just finishing my BSN, and my buddy said to me, "Hey, Pfeiffer University is coming up and they're going to do a cohort. Let's get our master's." And I was like, okay, I'm in. And from there, I started studying healthcare information technology. And by this time, I didn't have a lot of things to fix at the hospital anymore. And that's what I thrived on. And so they were like, "Well, we'll make you over this. We'll give you the IB team. We'll do this." And I was like, I just don't want to be a maintainer. And as I studied healthcare IT, I saw a lot of broken stuff, right? So I jumped in and I got a job with a company called Cerner, which is an electronic medical record company that was since bought out by Oracle. And then from there, I got my doctorate degree while I was there because I just felt like I had to do it because I'm an overachiever. And from there, I decided, what am I going to do with all this knowledge? Like, I don't want my boss's job, And so I sat down and wrote a book called How to Avoid Being a Victim of the American Healthcare System, which is available on Amazon, to teach the 17-year-old me what they should know before they ever access the healthcare system, and give back in that way, because it's a scary jungle out there. Medical errors are the third leading cause of death, and patients need to be empowered. They need to be knowledgeable before they access it. So I did that, and I still have a career in healthcare IT, not with Oracle anymore, but with another company. And so that's basically my story.
Well, Dr. Wilcox, we're grateful that you are joining us today and just excited to dive into these questions and hear your insight. And it's just, it's fascinating to learn that your experience with the healthcare system, and also seeing where the healthcare system is broken and needs to be improved, began as a father taking your daughter as a patient to health appointments, and seeing issues, and having to navigate the healthcare system now, and the way that that theme has allowed you just to progress in your career, and that started at a young age, providing care for your daughter. And so, as you mentioned, you've written a book, fantastic book, by the way. Highly recommend it to all the listeners out there. And I'm curious. We're going to dive into this topic of navigating the American healthcare system. And so, in your experience, what are the most significant barriers that both patients, but also healthcare staff face when trying to understand and navigate the American healthcare system?
Well, we could probably be here for several hours, but I'll hit on some highlights. So most patients don't know, like, let's take surgery, for instance. Most patients don't know that if you're the first case of the day, your statistics are better, right? Because the surgeon comes in, they're refreshed, you're the first case, and they're not tired. And also, they don't know what questions to ask during the surgery interview. So, they can ask, can I be the first case? But they also should ask, are you on call the night before? Because if they're on call the night before, then they're maybe not so refreshed when they come in. I actually had a guy read that chapter in my book, and then he had to have surgery. And the doctor looked at him finally said to him, are you a doctor? And he said, no, I'm just an educated patient. And he said, well, you've done your homework. So there's things like that. The other thing that stands out to me is not a lot of people know if they're going for an elective surgery, they can bag up their own medications, take them to the hospital, and ask that the pharmacy use those. Pharmacy really doesn't like that much, but it saves them from getting the $50 Tylenol. There are so many things that people don't know about the healthcare system. And one thing that I really stress is, if you're not knowledgeable about the American healthcare system, because it's not a matter of if you're going to need healthcare, it's a matter of when, then you need to get knowledgeable, because you can't walk into a healthcare system thinking that everybody's going to do the right thing. Even though they're trying to do the right thing, there are stressors, right? There are insurance companies who want you to see so many patients a day. There's short staffed, and nurses are flying in and out of the room, right? So not good by design, but it does happen. So you really do have to be knowledgeable.
In your experience, Dr. Wilcox, what lessons have you learned from leading efforts that improve both patient and staff engagement in healthcare system, and helping both your patients and your staff navigate the healthcare system? What have been some key lessons or key takeaways that you can share with us today?
Well, first of all, I think I'll start with the staff piece of it. So, the staff want to do a good job, but they're between a rock and a hard place, right? Because the payers want to pay a certain amount, and the staff just want to take care of patients. They're not opening a book to see, hey, is this cardiac cath going to be covered by the insurance company, right? They're trying to do the right thing. I can remember at a hospital that I was at in North Carolina, there was always short staff. Yeah, they were always short staffed. And so they would offer like $15 an hour for a nurse to come in and work extra. And I remember seeing some people who work 60 hours a week, which is not really the safest thing to do, and so I was walked up behind these two nurses up on the fifth floor one day. And I heard one nurse say to the other nurse, hey, I'm going to call in Saturday. Why don't you grab that $15? So I started to understand it was kind of a gaming of the system. So I decided I'm going to do something different. I'm going to do some research. And I found this article on this hospital up in Albany, New York, that had done something different. And so I took that information and tailored this program called Worked Hours Reward Program. I want to call it Worked Hours Incentive Program, but the CNO said, we're not calling it WHIP. No way, David. So what we did with it was we just said, if you're full-time and you work your 80 hours a pay period, then we're going to pay you $250 bonus just for showing up to work. If you work a 0.9, then it's going to dip to like 175. And if you work 0.5, it's going to dip to like 125. And so why we did that was because staff were getting burned out, and we didn't have what I would call the safest care at that point. So what happened was all these PRN staff, they said, well, I'm going to work the 1.0. So they bumped their hours up. They removed things on their own personal schedules to come to work. And then the 0.9s were like, hey, I want to pick up an extra shift so I can get the extra money. So it just kind of evolved into better quality outcomes for patients, because we talked about patients before, and much more satisfied staff because they weren't working short anymore. And if somebody called in for legitimate sickness, then they just worked with their manager to pick up a shift if they wanted to keep the money. We saved the hospital system like $2 million doing it this way, as opposed to just throwing, cash on top of a burning fire of staff shortage. So, yeah, that was kind of cool. I really like that. My CNO actually took it and presented it at a conference. It was just very forward thinking. So,
Well, and I just think, Dr. Wilcox, that speaks just the importance. You mentioned that initiative started with you listening to staff and hearing a conversation, and then doing research and finding a hospital that had implemented a similar program, and then taking that research and implementing that same similar program into your own hospital. And I think that just speaks to the importance of content like this, to allow people to share what works, what doesn't work. How do you navigate significant issues like burnout and staffing issues? Because those are things that healthcare systems and organizations face all the time. And so, Dr. Wilcox, shifting gears a little bit, we've talked just on some barriers on navigating the healthcare system, and it's a complicated healthcare system to have to navigate. And we're going to dive some more into how clinicians and clinical leaders can empower their staff to help patients be able to now navigate the system better. But before we get into that, I'm curious to hear your thoughts on just the challenge that healthcare disparities remain, and how, when trying to implement some of these patient empowerment and staff engagement initiatives, and make those a priority, how your clinicians and leadership can ensure that they are, in doing so, are trying to reduce those health disparities and reach vulnerable and underserved patient populations. So how can they navigate health disparities while trying to make sure that patients are empowered?
so one thing that you touched on was listening, right? You have to listen to your patients. The other thing is we now have tools that we never had years ago, such as population health tools. So we can pretty much hone in to see what zip code, what people who are less fortunate are in, and if there's been flu outbreaks there, or COVID or whatever. And then what we have to do as leaders and clinicians is we have to go to the people. So uh, setting up a farmer's market in a place where they don't have access to fresh food and vegetables, and subsidizing it. I've seen that work really well. The other thing is, setting up a spot to give flu shots, or, COVID shots into an area where you have a farmer's market, or into an area where people that don't have a lot of means can actually access some place where they will go. And reaching out to the community, and developing those bonds with the community. I think that that's very important. I think that if you don't reach people where they're at, and you're expecting them to come to you, you're going to have a much sicker population.
Dr. Wilcox, I'm interested to hear your thoughts on this next question. A common complaint I hear, and that is just prevalent throughout our healthcare system, is burnout, but more specifically, administrative burdens that your clinicians and frontline medical staff have to deal with. That is on top of having to take care of patients and provide care for those patients. Obviously, we can't just eliminate all of administrative tasks. But in you've spoken just the importance of empowering patients and helping them navigate it, and empowering your staff. And so, how can your clinicians and leadership create environments where the frontline staff, your clinicians and other medical staff, have the time and ability to support patient empowerment without adding additional administrative burdens?
So let's talk about something that I'm sure every clinician can relate to, who's watching this. So when we digitized the health record, we created a huge burden, right? All of a sudden, docs were having to type in orders, and they're like, "I'm not a typist, I don't do this." They want to take care of patients, right? So we created all these burdens in the sake of producing data from a medical record and being able to understand it, making it safer than the doctor with the lousy handwriting who writes for a prescription that the pharmacy misinterprets and the patient gets the wrong medication. Those were all needed, but those were very burdensome. So now what we're seeing, and especially after the COVID epidemic, or pandemic, I'm sorry, we've seen things grow out of that, like virtual nurses, right? So it's very easy to set up. You get an iPad, you get a PC, whatever. Zoom is HIPAA compliant. I mean, you can use that. You can use Teams, which is also HIPAA compliant. And you say, hey, this is your nurse, this is your tech, and this is your virtual nurse. And the virtual nurse actually does the whole admission assessment, which takes nurses quite a while to do. But the beauty of it is that nurse also has time to teach the patient about their new prescriptions or their new diagnosis, while the other nurse is tending to the tasks that need to be done for patients, being boots on the ground at the hospital. We've seen some remarkable results with that. And then also they can go over the discharge teaching in depth because, let's face it, discharge at a hospital is I walk in with a bunch of paper. I say, hey, you got your new CHF diagnosis and can you sign this form here? And the person's like, I just want to get the hell out of here, right? So it's like total chaos. This lessens the burden on the actual nurse who's providing care at the bedside and gives somebody who wants to do that kind of work the ability to do it. Now let's move on to what I think is really going to be a game changer in reducing administrative burden, and that is artificial intelligence. And I know before I get shot, some people are like, no, artificial intelligence bad. But if you train it right, it's good, right? I mean, everybody was afraid of email at the beginning too, right? So sending stuff off on the internet. But the artificial intelligence allows a doctor to go into a clinic with a little device or a phone and say, hey, I'm going to record our conversation so that I catch everything. Is that okay? And the patient says yes. And then that note is produced for the doctor. So he doesn't have that administrative burden of trying to remember at the end of the day what he did for that patient, as well as the other 10 patients he saw or she saw. So it's like those kind of tools are invaluable. And I've seen some work on what we call voice for nursing out in the healthcare IT industry, which when you think about it is beautiful because normally I would go in and do an assessment on you, Zach, and I would use a cold stethoscope and I'd listen to your lungs and I'd listen to your bowel sounds, check you for edema. And then I would go off somewhere, maybe with a cup of coffee, maybe not, and I would chart it. And you'd be like, I wonder what that nurse found, right?
Yeah.
And so, so what happens now is they hit a little device and say, hey, Oracle, since I worked for Oracle at one point, they say, doing my head to toe assessment, and they'll say, oh, I got crackles in the left lower lobe. And the AI can speak to them and say, did you check for peripheral pitting edema in the peripheral extremities? And the nurse is like, well, yep, got 2+ pitting edema in the peripheral extremities, giving the new nurse like the 20-year advantage, right? Because those are things that you don't learn right coming out of school. But also the beauty of this is now the patient can say, well, is that why I take that water pill? And the nurse can say, yeah, and you're probably going to take 2 of them today. So, it brings them in and makes them feel a part of their care. And of course, nursing leaders really have to rewire nurses' brains to be able to speak that kind of stuff in front of a patient. Because most of the time, if you've got a lot of patients, you want to get in the room and get out of the room, right? But this gives the opportunity for the patient or family member to ask questions. And I think that we'll actually see increases in HCAP scores because of things like this. But don't be afraid of artificial intelligence. Just make sure it's trained correctly and get comfortable with it.
Well, and that's fascinating to hear you walk through a couple of those examples because in doing so, those nurses want to get into the room and get out of the room because they have to spend time charting, and if they don't chart effectively and efficiently, they fall behind on spending time in the room. But also there's liability issues and legal issues that can come from that. And so they feel that strain. And it's fascinating to hear you mention some tools that will keep your clinical staff in the room longer, which inherently deepens and broadens that patient provider relationship, which is empowering. If you get more time with the experts, as in your clinical staff, those patients will have more opportunities to be empowered and to understand and to help navigate the system. And so I
Yep.
think that's fascinating. Something you're curious, something that just piqued my interest is you said if it's trained correctly. You mentioned that a couple times. How
Mhm.
how do you make sure it's trained correctly?
There's various ways to train AI. So in my what I know about it is basically we we started AI in a clinic, right? And we started it for family health providers, family practitioners, or nurse practitioners or PAs in that area. But if we rolled it out to somebody who is in endocrinology, we would have to train it for the terms that are spoken in endocrinology, right? So there's those aspects. You kind of have to make it specific to what the venue is. Not that we didn't have people take it, like in cardiology, and say, "Hey, I'll just work with it because this is great." But we kind of got to train it for the specialty, and that's the same way with nursing. You can say, hey, whatever, Google, Oracle, whatever. I just placed a 16 French catheter, Foley catheter, and I got 300 cc's of clear yellow urine. And then the AI might say to you, was that your first attempt? And then you might say, no, it was my second. So it documents everything correctly, but it's got to be intuitive to your workflow. Like I said before, when we started this conversation, the electronic medical records created a huge burden for clinicians, though we needed to do it. But now we're getting some tools that this is the cool stuff, right? Let's go do this. We can get more time with our patient. I could spend more time in the room because I don't have to go out and write that note. And so this is the kind of stuff that clinical leaders need to be on top of. They need to embrace it and they need to sell it to their staff. And as I mentioned before, nurse managers have to teach nurses to do it differently, but they get the benefit of you're not going to have a lot of nurses hanging around at the end of shift getting overtime, right? So it's also going to increase your bottom line, which hopefully allows you to put more money into other things in the unit than nurses who are overworked and stay in 2 hours later to do their documentation.
Right. You've touched on this a little bit, but I want to maybe touch on it in a different way, in a different light. But when we're talking about healthcare systems and just the complicated nature of the American healthcare system, there's a lot of clinicians that feel powerless and disillusioned with the system because it is so complicated, and they want to help, but they can't help as to the best of their ability because of limitations and red tape, and having to navigate that system is just something that is very complicated. And so how can clinicians and leadership help clinical staff see themselves as agents of change and as people that are helping other people rather than just cogs in a system that is yeah, how can they avoid the being cogs in a system and how help them see themselves as agents of change?
So that's an excellent question because over my career, I have seen organizations try to make clinical improvements without involving clinicians. That never works well, and clinicians feel like, oh, this is coming from the top down. We have to do it. So the big thing that clinical leaders need to do is they need to incorporate um, clinicians into clinical decisions. It seems like a no-brainer, right? But a lot of times it's the finance people, it's like other people are making these decisions. So I would strongly suggest that if you're going to make a change, maybe you're implementing a new electronic medical record, or maybe you're looking at a workflow and trying to make it more efficient, that if you don't involve clinicians, it's never going to fly. I can't think of one instance where I've seen an organization not involve clinicians and it worked. It's just like a no-brainer. But so clinical staff want to be involved, right? I mean, I wanted to be involved in, making steps better for the staff that I did at that hospital in North Carolina. But they want to be involved. But if, as clinical leaders, we don't tap into that invaluable resource and get them involved, then we're setting ourselves up for failure.
Dr. Wilcox, we're grateful for your time today. And just before I let you go, I have one last question. What advice would you give to clinical leaders, clinicians in leadership who want to champion patient and staff empowerment, but aren't quite sure where to start?
Sure. So the first thing I would say is round. I remember when I was a patient placement director, people felt a connection to me. So if I said I went into the PACU and I said, "Look, things are going to be slow going up on the ortho floor today," and they were, so I got them prepared for what was going to happen. I think that you have to listen to your staff, right? That's the big thing, and then you have to set realistic expectations as a clinical leader. Um, and so another thing that I think we have a big gap in as far as patients go is when we release patients and we discharge patients, we send them off into the wild. We don't know, where they're going, what they're doing. We might have a street address or whatever, but when they have questions, it's very hard for them to get answers. So they go, where do they go? Dr. Google, right? Let me get there. And that's a terrible thing to do. So, they can't, we should have places where they can call back in the hospital and say, hey, went to get my antibiotic, but it was like much more money than I could spend on it. And so, what can you do for me? And well, we write you a prescription for something that's generic. And those kind of things are a big gap. You don't see a lot of people paying attention to that. They want to get them in, get them out, and be done with it. And they don't really get reimbursed for it either. So that's the other piece of it. But those are the kind of things that I would suggest, ways we could improve the patient experience and ways we can improve and be successful in getting across clinical changes that we need to get across. Involve your clinical staff and have an avenue for your patients to go or call after they get out of the hospital when they have questions.
And I love the emphasis on listening to your staff, listening to your patients. And the other thing that I would add to that, just if you're a clinician in leadership or a healthcare leader out there that doesn't know where to start on how to do this, there's a great book on Amazon called "How to Avoid Being a Victim of the American Healthcare System" by Dr. David Wilcox that offers a lot of unique insights and it just practical tips on how to be empowered and, as a result, better empower others.
Yep. And you can find me also at drdavidhelps.com, drdavidhelps.com. I have a healthcare resource guide, which is a one-click access to things like Mark Cuban's online pharmacy. I have even insurance, even companies that will take your hospital bill, look it over. And if they can't save you any money, they don't charge you anything. And if they do, they take a third of what they save you. There's all kinds of resources up there, which would be very difficult for most lay people or patients to find, and even clinical staff. But it's available there. And if you sign up for my newsletter, I'll send it to you. drdavidhelps.com.
Well, Dr. Wilcox, we're grateful for your time today. Grateful for you coming on to the Clinicians and Leadership podcast and sharing your insights and your expertise on how we can better help patients and staff navigate and understand the healthcare system as a whole. So we're grateful for you and we wish you the best.
Thank you, Zach. Appreciate it. I enjoyed talking with you today. And remember, everybody who's listening, do your education. Make sure you're safe in the hospital.